Thanks very much, Ben, for that introduction, and it's a real privilege to be here today. To misquote Chris Bishop, who's head of the Microsoft Research Lab in Cambridge, in the future, there are two types of doctors, those that are working on AI now and those that will be working on AI. And it's a real privilege to be standing here, hopefully to be in the first camp. I'm also really grateful to Olivier and Tanvir for setting the scene with a lot of what I'm going to talk, specifically talking about the issues of segmentation in radiology and in combining both imaging and non-imaging data. And they're looking at it for radiology, which is a really big field, a grand challenge, if you will. And what I'm really excited about as a radiation oncologist is that radiation oncology represents an interesting microcosm of the radiology problems, but one where we might go ahead and make some tractable progress into developing solutions because the nature of the problem is a bit more contained. And that's why this collaboration with the NRI team at Microsoft has actually come to fruition. So first of all, some boring stuff. These are the people I work for. These are the people that pay me, but no one's telling me what to say. So just in overview, just some of you may know a little bit about radiation therapy and our workflows and the role of imaging within that workflow and why it's particularly attractive to work on. So I'll talk a little bit about that. Then to talk a little bit about machine learning in segmentation for radiotherapy contouring and the progress that we've made with the NRI team. So that's looking at solving problems that we face right now, but it also means that we have potentially tools to solve the problems that we're really interested in looking further forwards, which is in adaptive radiation therapy and in predictive radiomics for radiation therapy. And what I want you to hopefully leave the room is to think that these things can't be done at scale without machine learning or some form of similar technology. So radiation therapy, well, it's been around for 105 years now using X-rays, high-energy X-rays, to destroy cancer cells whilst they're still within the body, often as an alternative adjunct to surgery. And that's done by damaging the DNA within these cells, if you like, the source code that cells need in order to be able to perform physiological functions and to reproduce. And of course, the key thing that we rely on is the fact that healthy cells in the body can repair DNA damage, whereas often tumor cells, as part of the process of carcinogenesis, develop defects in DNA damage repair. And we're relying on that differentiation to target the effects of radiation more towards the tumor than the normal tissues. But of course now modern radiotherapy, particularly there's more engineering in the beam delivery systems, means that we can now spatially target that tumor as well. So we're not just relying on those biological differences, we're also relying on our ability to locate and target the tumor precisely. And that's really where the imaging comes into radiation oncology. So what I want you to see now is to understand is that this is a real cutting edge treatment technique. So this is an example of the brain Abnormality system, which we had installed in our department this year. It's a very sophisticated imaging system. We have a CT gantry that's mounted at 90 degrees to the actual treatment beam here. We have a robotic couch that can reposition the patient. And we have, as you heard before, a surface monitoring system that detects the external position of the patient 60 times a second, combined with orthogonal X-ray imaging too. And it can use all of that information together in order to make sure that we have absolute geometric certainty of our positioning of the patient before we put the beam on. Now, you may not realize this, but modern radiotherapy is a very curative treatment too. If we look across the distribution of patients that are cured of cancer, surgery clearly is the main contributor, but then radiotherapy used as the primary treatment of 40% of all of the patients cured of cancer. A lot of what you hear is on chemotherapy and systemic therapies, which undoubtedly plays an important role as what we call an adjuvant, so combined with other treatments. But on its own, chemotherapy only cures about 1 in 10 patients with solid tumors. And it's also a very cost-effective treatment too. So this is a representation of how much the UK NHS spends on cancer treatments. And you can see that radiotherapy, despite that effectiveness, only consumes about 5% of the cancer spend. So it's a very cost-effective therapy. So you can see that there are clinical drivers for why it might be interesting to explore this space. Now, if we think about the actual radiotherapy, you'll see again there are reasons why this might be particularly interesting if you come from an imaging background. So it's a very simple workflow that we have to do. We have to scan the patient, produce imaging that is representative of the patient's tumor and healthy anatomy. Then my job as a clinician is to actually segment and label that anatomy, and as I'll show, it takes me an awful long time, and I'd rather it didn't. Then we actually have to plan a set of radiation beams that are focused on the tumor and actually hit the tumor while shielding healthy tissues as much as possible. And then we actually have to deliver those treatments. So when we're scanning the patient, we're using CT for spatial accuracy as well as getting electron density data for dose calculation. And we use machines like this. I chose a Siemens one, of course. So what you can see, it's like a standard CT scan. It has a larger bore. It has a completely flat carbon fiber top so that the patient is fixed very rigidly onto that. And we typically mount devices onto the edge of this couch that keep the patient in a specific position that's used for the treatment, what we call immobilization. And once we're able to do that, when we can acquire that CT data set, but oftentimes, particularly, I'm a neuro-oncologist, we can't see the tumors that we want to treat, like a low-grade glioma, on a CT scan. So we often have to combine MR and PET in order to actually be able to see our target too. Okay, so then this is my big bugbear. It takes an awful long time to actually draw around your tumor target slice by slice. And then, of course, you've done that and you think you're finished, and you have to go back and outline all of the healthy structures. And we've seen already some automated systems for doing this. But all of these structures have to be defined in radiation therapy, because if they're not defined, then the computer and the optimization algorithms that position beams don't know about them. So it's a very, very important issue. So we typically use fairly standard computational pencil beams to actually calculate the way that dose is deposited into the tissues. It's very similar to ray tracing, in fact, so you'd be familiar with the same algorithms. And then to ultimately decide which the best arrangement of beams is, because we can bring in beams from hundreds of different directions, and we use small beams that can be turned on or off in intensity whilst the machine rotates around. It is a high-dimensional numerical optimization problem. And again, we've borrowed solutions from that space. And then we actually get to deliver the treatment. There's lots of interesting technologies for treatment delivery, but I won't really go into that today. So my real interest is in using machine learning for the contouring part of radiation therapy treatment planning to get my goal of pixel perfection. So why is pixel perfection important to me? Because this isn't just a CT, or in this case, an MRI scan. For me, it's, as we heard that phrase, the digital twin or the radiology twin, which I really liked. It's a representation of my patient for the linear accelerator. And every pixel in the data set has to be labeled somehow because it's going to be considered in the dose calculation. And if it's not there, then you're going to make very, very silly mistakes. And those mistakes are going to propagate all the way down the workflow. There's no point having the machine like I showed you, which has sub-millimeter targeted precision for radiation therapy, if we're a few millimeters out in defining our targets or our critical normal structures. And the trouble is that existing clinical workflows aren't great. They are sort of 2.5D. They work on a slice-by-slice basis, reflecting the acquisition of the imaging. We have to rely on image registration techniques, and often we're using multiple image data sets and transferring representations of our underlying anatomy between all of those data sets isn't great. It's very operator dependent, and it's clear, and there are multiple published studies, that there's poor intra and inter-observer consistency, and that matters. So this is an example, a case I had to do last week, a young patient of mine who had a complex recurrence of a tumor where the disease came back in front of the brainstem and in the spine. So we used the CT data set in order to get the spatial data, but then because he had tumors in the brain and in the spine with different imaging characteristics, I ended up having to fuse 4 MRI scans in order to be able to do my segmentation. It took 2.5 hours. So these things really matter. This is an example of a clinical trial where they were looking at adding a drug into radiation therapy to sensitize the most hypoxic clones of the tumour, so the most radio-resistant cells to the effect of radiation. And as with all good clinical trials, there were very clear instructions for how the radiotherapy segmentation should be done. Because, of course, in a clinical trial, we're taking radiation, we're adding something to it, and evaluating the effect. So we want the radiation to be constant. But what we actually found was that the study didn't demonstrate its primary endpoint of the effect of the new drug. What it did demonstrate was that if you looked at the quality of the contouring by what we call protocol violations, then the patients where the segmentations were not of a good standard actually had a poorer tumor control and a poorer survival. Okay? So these DICE scores for segmentations translate into patient survival. And one of the comments from this paper is that once you get to a reasonable level of spatial resolution, actually consistency is favored over the spatial accuracy when you're combining drugs and radiation together. It's quite an intriguing idea, particularly for machine learning. So at Microsoft, it's been a real honor for me that they have chosen to look at radiation oncology as a sort of exemplar of the problems that we face in radiology, largely because segmentation is a key part of the workflow. It's a rate-limiting step, and until that's done, we can't get on with treatment. And we've been working together on some simple forest-based segmentation tools for segmentation of the tumor targets and healthy tissues. The first one that we developed was actually for prostate cancer because it represents 40% of all of the radiation therapy that we do. And that's typical of sort of Western and European practices. And what we did was to establish sets of target performance with DICE scores that we would like to see both on the tumor but also on other surrounding structures too. And the forest segmentation was trained on data sets of around about 120 patients coming from a group of collaborating institutions. So this was one of the nice things. So I ran some numbers earlier this week with the tool and comparing it with our in-house Atlas-based auto-segmentation. So for those of you that aren't familiar, this is the workflow that an Atlas-based segmentation tool has to do. Some pre-processing is required, and then it will generate two orthogonal projection X-ray images, and it will use those images to find a match in an atlas of similar patients that have already been fully labeled. It then runs a 3D deformable image registration, which on our system is the thing that takes the most time, and then you have to transform to the new reference frame and do some post-processing to fix up. It's about 10 or 12 minutes using our system. That's with a fairly hefty CPU and GPU acceleration. Running on a standard workstation, our forest-based classifier is able to produce similar output in about 20 seconds. And then what we did was we actually ran a comparison with 4 commercial Atlas-based auto-segmentation techniques. Often they're not using a pure Atlas-based auto-segmentation. They have some model-based element for doing fix-up too. And we compared our conformity indices for the tumor targets and for the normal tissue structures. And it was nice to see that we were doing at the top. And that wasn't because we did the evaluation on our testing data set. This was on an independent data set. But to me, seeing these numbers, what's quite interesting is that if you're on a trial management group of a radiotherapy trial, one of the things that you do before you allow clinicians to join your study is to send them homework. And you ask them to perform segmentations and you compare it with the output of your experts in the trial management group. And typically we'll see Interobserver conformity indices of about 70% if you're using CT data only. With MR and functional imaging, obviously, the bar goes higher. And intra-observer conformity of around about 80%. So kind of thinking about like a sort of little Turing test, you know, we're actually getting better conformity levels with the algorithm, perhaps, than our experts are getting peer-to-peer. So we know we're in the right ballpark. So what does this make a difference to me? Well, it matters a bit in my day-to-day work. A glioblastoma case like this would typically take 80 to 90 minutes. With our GBM-ML model, it takes about a minute to segment, and then we use a second assistive tool for doing the fix-up very quickly. But the real point about that is that that gives me time to go back and focus on patient care, because then I can actually think about functional consequences of the radiation therapy that I'm treating using my other interest, the multimodal MR, and think about how I might individualize treatment for that particular patient rather than spending all my available time in simply doing the segmentation. Okay, so that's all talking about a problem that we face right now in terms of the day-to-day work, hundreds and hundreds of patients coming to radiation oncology clinics requiring this segmentation burden. But in the future, I want to go further than that. I want to be Mr. Super Radiation Oncologist. And there are two things that are going to let me do that. The first is to bring about adaptive radiation therapy. And that means that we continuously adapt our radiation treatment to changes in the tumor and the normal tissue structure that occur during radiation therapy treatment. I'll show a slide about this. And the second thing is predictive radiomics, which means that we actually refine our prediction of the side effects of radiation therapy by using imaging and baseline toxicity data and toxicity data that's acquired whilst the patient goes through their treatment too. So coming to what Tanvir was talking about, combining image and non-image data. So this is the thing, okay? Radiation oncology, if you want to floor any radiation oncologist at a cocktail party, you ask him about this elephant in the room, okay? So this is a patient, scan of a patient on the first day of radiation therapy, and they have this big lymph node in the neck because of a tumor that's occurring in their parotid gland, slightly higher up. And typically, in order to make radiotherapy safe, we give radiation therapy for curative reasons over about 5 to 6 weeks, typically about 30 treatments over 5 to 6 weeks. So of course, if the treatment works, and in this case it has, the lymph node has shrunk, and so if we look at our original high dose area, that's now including some other normal tissues that don't really need to be there. So that's one situation because the tumor shrinks. This is another interesting situation. So this is a lady that's got a very advanced tumor of the endometrium and the womb, and it's actually due to the effect of the tumor bulk interfering with the function of the bladder that sits very close to it. So when she came to start treatment, her bladder was rather full. She then starts radiation therapy, the tumor responds, and she can now actually void her bladder, okay? Now, the bladder being a very dynamic structure, clearly changes in bladder filling have a significant effect on the local anatomy in the pelvis. So again, we're covering our eyes, you know, to treat a patient on the basis of this configuration when this is actually happening maybe some weeks down the line, okay? These are important things. So what we really want to do in adaptive radiation therapy is we want to prepare our initial treatment plan. And of course, we'd like to use machine learning to improve that workflow, as you've heard. We then want to rescan, resegment, and replan every day of their treatment. And ideally, we'd like to do that whilst the patient's on the treatment couch, so we've got about 5 minutes. There's various interesting disruptive technologies coming that will help us do this. This is a solution from Electa, which is actually an MRI Linac. So it's an MRI that's been cut in half and a radiotherapy machine actually inserted in between the two. So MR has no radiation dose, so you can image continuously during treatment, which is very attractive. This is ViewRay, which is another system that uses a similar type of device using 3 positions here that rotate around in a gantry. And this can either be a linear accelerator, electrically generated X-rays, or it can use cobalt, which is naturally occurring X-rays. But it's the same principle. And then again, I'm no longer on Siemens payroll, but this is what I would really like. Okay, I'm interested in functional MR imaging, quantification of changes in the tumor during treatment. So I would like to be able to have an MRI scanner on a gantry or a robotic system that would move my patients out of the radiotherapy unit into an MRI scanner, image what's actually happening to the tumor in terms of metabolism, oxygenation, pH. So tumors taste different when they respond to therapy. Bet you didn't know that. Okay? And I'd like to be able to respond to those kind of changes. That's what I really want to do. Biologically adaptive radiation therapy. Finally, this is all very well and good talking about how much dose we can actually put into the tumor. There is a patient around about the tumor as well. And this is the problem that we face. If we look at how much radiation dose we put into the patient, the more dose we put in, the higher the chance of controlling the tumour for a population of patients, but also the higher the chance of injuring the surrounding tissues. So we have to make a compromise at a population level of what risk we're prepared to accept. Now, predicting tumour response for an individual is quite tricky. You have to use serial imaging, some of the biomarkers, and there's a lot of work in that area. But it may be possible to predict normal tissue injury from an individual patient because the response of a population is quite well characterized. And that's where I'm quite interested in combining, perhaps potentially using things like the multitask Gaussian process model so that we learn from the advent of both positive and negative toxicity. So in other words, did the patient get proctitis? Did the patient develop bladder symptoms or not at this point during radiation therapy? To then guide and individualize our assessment of the likely toxicity of outcome. Because for a lot of tumors, there's an interesting observation, which is that if you can give 1% more radiation dose, the chance of cure will increase by 1 to 2%. So that means that if you have a tumor that is already at about 50 to 60% chance of cure with radiation, if you can squeeze in 5% more dose, you can increase the cure rate potentially by 10%. So small differences might really matter for some patients. Okay, so that's a brief overview of where I'm thinking. Hopefully what I'd like you to understand is to think maybe, just maybe, your colleagues working in radiation oncology might be able to consume some of these technologies and give you feedback, because they're a group of patients that we image and study more intensively over a short period of time, and the event rate is higher. We see more observations whilst we're actually treating those patients. So I'd like to thank my colleagues who worked at Microsoft Research, my clinical colleagues, and also in particular to Ben and Enda for offering me this opportunity to talk today. Thanks very much.